Good morning. I'm Shiba, from the Associate Professor from the Department of Community Health Nursing, Sri Balaji College of Nursing from the Bharat Institute of Higher Education and Research, Chennai. So I'm going to tell about the topic infertility from the genetic subject. We'll see the outline, what are the things we are going to deal today. Introduction of infertility, definition of infertility, risk factors of infertility, causes of infertility in men and women, types of infertility, diagnosis of infertility, treatment of infertility, counseling for infertility couples, and ethical and legal aspects of AIT. What is infertility? Introduction to the infertility is about it is a significant social medical problem affecting couples worldwide. So nowadays, most of the couples are facing this infertility problem. The infertility refers to an inability to conceive after having a regular and protected sex. Average incidence of infertility is about 15% globally, that is varies in different populations. Some causes can be detected on treatment and whereas most of them are unknown. According to the Mayo Clinic USA, the 20% of cases of infertility are due to the problem in men, and 40 to 50% of cases are due to women, and 30 cases are due to problem in both men and women. In India, approximately 50 to 20% of couples are infertile. What is the definition of infertility? The infertility is a failure to achieve a birth ever with 12 months of unprotected intercourse. Infertility is an ability of a sexually active, non-contracepting couples to achieve pregnancy in 1 year. So these are the risk factors of infertilities among the women. One is the past cancer. So if they have any previous history of cancer and irregular periods and history of sexual transmitted disease, if they have a habit of smoking and drinking, if the age is above 35 and the obesity. So all these are giving risk for this infertility problem in worldwide and the women. And causes of infertility in men and the women. So the main causes in men is about the low sperm count. If the sperm count is low, so it is not able to the sperm to get fertilized with the ovum. So the sperm count is less than 10 million sperm per ml of semen, and the normal count is about 20 millions of sperm per ml of semen or more. No sperms. If the sperms is in absence, that is also a process. The low sperm motility. That is, you can see in this picture, the motility of the sperm is must. It has to go and reach the targeted place. The sperms are immotile and cannot swim and it reach the targeted space. Abnormal sperms. If the shape of the sperm is abnormal and it is more difficult to remove and fertile the egg. Mainly the causes for all these are it may be of testicular infection, testicular cancer and the testicular cancer. Next, in men, the slow sperm count and the no sperm is also the major problem. And overeating testicles, if they have occupation which is related to oversitting or a strenuous exercise, strenuous job, and that all causes the testicle to get overheated and the sperm may they don't have a proper sperm count and the motility won't be proper. So all this problem will happen when they have a overheating testicles problem. Ejaculation disorder, that is retrograde ejaculation. Next is varicose, that is if they have a varicose vein in the scrotum, that is also going to cause for the infertility among the men. Androsteneditis and hypogonadism, that is testosterone deficiency, genetic abnormality, mumps, hypospadiasis, chlamydial infection among the men. And in women, we'll see the ovulation disorder, mainly the ovulation disorder with the major cause, the premature ovarian failure, that is before the age of 40, high polycystic ovary syndrome, hyperprolactinemia, poor egg quality. Next, if they have any problem with uterus and the fallopian tubes, if they had any surgery, and submucosal fibroids, endometriosis, previous sterilization treatment, and the medications such as NSAIDs like aspirin and ibuprofen, chemotherapy, radiation therapy, and if they have any illegal drugs like narcotics, drugs, etc. Next, the types of infertility. So we have two types of infertility. One is a primary infertility and the secondary infertility. The primary infertility, when a woman is unable to ever bear a child. So that is called primary infertility. They didn't have any other child. That is called primary infertility. Second infertility, when a woman has been pregnant but failure to achieve live birth after having a live birth previously. So in secondary infertility in the sense, the first they would have had a one live birth child, but the second time they are not able to conceive and had a live birth. Next, what are the male infertility? One is the first is protection. Protection is hypothalamus from the anterior pituitary, from the testes. The protection is hypothalamus. So it is mainly due to congenital abnormalities of hypothalamus, example, Kalman's syndrome, and starvation, stress, or severe illness. Tumors like metastatic tumors and hypothalamus, and head injuries and inflammation, that is called sarcoidosis, and infections such as tuberculosis, and drugs like slergina, that is narcotics drugs, and the protections from testes, that is a congenital abnormality like Klinefelter's XYY in the developmental disorder, disorders of gonadal sterogenesis, and infections such as chlamydia, prostatitis, mumps, orchitis, and autoimmune disorders like diabetes mellitus, cryptorchidism, and tumors, chemotherapy, X-rays, drugs and alcohols, and vascular problems like testicular torsion, and the testis congenital infectors, and again this sorry. Next is the storage. Storage is temperature, mainly the rise in storal temperature of the patient, varicose, delivery is impotence, ejaculation, that is impotence, and if they have an ejaculation problem, neurogenic medications and the alpha blockers and metal dopa, endocrine diabetes, congenital, that is absence of vast difference, genetic cystic fibrosis, primary ciliary dyskinesia, that is Copten-Jenner syndrome, hypospadiasis, and vasectomy. So all these, and the history such as previous children's infections such as prostatitis, STD, mumps, orchitis, and trauma to the head or sometimes to the testicles, and surgery to testicles. Sometimes the hernia will also lead a mild infertility problem. And occupation, mainly the sitting. I have said that over sitting jobs like you can see tailoring people are they'll have over sitting, and that leads to that is it gives a the overheating testicle problem. Biohazards, if they are working with chemicals, so that may also cause some infertility problem among the men. And chemo and the radiation therapy, because that radiation that will affect the testes and the sperm count. And ethanol or smoking and some of the medications and medical history such as diabetes mellitus and the hypertension and previous investigations. Physical examinations like anatomy, we have to see the meatus, whether it is hypospadiasis or abuspadiasis, and the testicular size and the varicoses, rectal examination with prostasis and discharge you can able to find out, and other semen analysis like abstains, that is 2 to 4 days prior, at least 2 samples over different period of time we have to collect. We have to see the sperm count, sperm motility, and if abnormal, we have to go with FSH, LH, TSH, testosterone, and PRL. The testicular scans and the chromosomal analysis in order to find the Klinefelter type of problem. The first semen analysis is done by WHO in 1992. The volume about 2.0 ml, and the sperm count should be about 20 million per ml, and the motility should be that is in about 50 percentage the forward progression, or 25 about 25 percentage of rapid progression within 60 minutes. It has to be there, and morphology is about 30 percentage of normal forms it has to be presented, and WBC should be less than 1 million per annum. And the treatment and intervention is treat the underlying causes. That is the main things we need to find what is the cause of infertility. So according with that cause, we have to treat the condition. And the intrauterine insemination is a treatment, and intracytoplasmic sperm injections. And next is the fundectability, that is probability of achieving a pregnancy within one menstrual cycle, that is 25 percentage will be there. And fundecty, that is ability to achieve a live birth within one menstrual cycle, is about 6 percentage. And protection is protection, storage, delivery. In protection, we are going to see that is same the hypothalamus, pituitary, and the ovary. In this, you can see the hypothalamic pituitary gonadal axis. So how this hypothalamus, from the hypothalamus, it is sending the signal to the anterior pituitary, where the FSH and LH, where the follicles grow in response to FSH and makes the estradiol, and to the ovaries and uterus, where the estradiol stimulates the endometrial proliferation, whereas in the LHS, the progesterone is being produced, where the LH surge triggers the ovulation, corpus luteum, and makes the progesterone, and the progesterone stimulates the endometrial secretions. And the other diagram shows how the pituitary cycles, how it is being working with the ovulation, or with this menstrual cycle. And next is hypothalamus, the mainly the stress, exercise, eating disorders, psychogenic, and the congenital genetic Kallman syndromes, hypoxemia and hypoplasia, olfactory lobes of brains, starvation, stress, or severe illness, tumors like craniopharyngioma, metastatic tumor, head injury, and inflammation such as sarcoidosis, and infections such as tuberculosis, and the X-ray radiation therapy, and the drugs. So these are the some of the causes. In the pituitary, you can see Sheehan syndromes, and the tumors with pituitary adenoma, metastatic, and empty cellular syndrome, inappropriate gonadal steroid feedbacks, that is estrogen excess due to obesity and the tumors, and the estrogen deficiency because of aromatase deficiency and gene mutations, androgen excess due to adrenal or ovarian, and the PCOS, and the testicular feminization, that is 46XY chromosome, the absent androgen receptors, and the ovary is gonadal dysgenesis, Turner syndrome, or mosaics 46X and 45X0. Testicular feminization and treatment with radiation, treatment with chemo for childhood malignancies and premature ovarian failure. Storage is RPM is unless severe, uterine abnormality, Mullerian agenesis, that is Mayer Rokitansky, Custer syndrome, leiomyoma, and the luteal phase deficiencies. Then what is the delivery? The uterine abnormalities, vaginal septum, and the tubal disease such as infection, STD, PID, rupture appendix, septic abortion, endometriosis. History collections, like we have to see the age, GPPL, regulatory of periods, prolactin signs and symptoms, thyroid signs and symptoms, infection, surgery, medication, smoking, ethanol, medical history, previous investigations, etc. And what are the examination can be done for this infertility is thyroid tests, because we need to find whether the patient is having a normal thyroid secretions, whether the patient is having irregular periods because of thyroids, and the breast, abdominal, they have to see the breast examinations, abdomen for the mass and the scars, and the vaginals for any abnormalities, and the bimanual, that is uterus, in order to find any masses, and the investigations like thyroid stimulating hormone, prolactin hormone, D3 follicle stimulating hormone, D3 luteinizing hormone, and the luteal phase progesterone. And in ultrasound, we have to do the pelvic ultrasound scan and assess HSC. The diagnostic procedures like laparoscopies can be done in the later stage. So this is the procedure that we are going to do, the intravaginal scan, that is through the transducer we have to do the scan investigation, and through the laparoscopy we can able to find the abnormalities which is inside the uterus. Next is the for the ovulation, how can you find if any problem with ovulation? Through the basal body temperature, or with the ovulation kit, or with some hormone tests like steroids, and the post-ovulatory blocks like laparoscopic fibro-optic look and hysterosalpingogram with the help of dyes, post-coital or cervical mucus and sperm antibodies, and endometrial biopsy. Next is the treatment. So we have a more amount of treatment for this infertility and ovulations, that is clomiphenol injections can be done with the intrauterine insemination. Next is gonadotropins can also be done with intrauterine insemination, and IVF, which is most popular treatment with infertility. It is a bilateral tube. If the patient is having a bilateral tubal disease, they'll go with this intravertine fertilization, and unexplained infertility after gonadotropin plus intrauterine insemination failure. So if we can't able to find any causes, even though if they taken a treatment with intrauterine inseminations, if they get failure, they will go with the intravitreal fertilization. Next, fertilization of all the above. And next, ICSI, that is mainly if the patient problem with the male factor, so they'll go with the ICSI, and unexplained infertility, which we don't find, we are not able to get a cause, so then they'll go with this ICSI. Next is in men, what are the problems? Premature ejaculations or erectile dysfunction, so that many treatment is behavior approaches can be done. We can do most of suggestion for this type of patients, and that is the erectile, in order to prevent the erectile dysfunctions or premature ejaculation, we have to give them a lot of behavioral changes in their lives and certain medication in order to prevent the premature ejaculation or some erectile dysfunction. Next is varicocele. So if there is a varicocele in the scrotum, it can be easily surgically removed and can be treated. Next is the blockage of ejaculatory duct. The sperm can be extracted directly from the testicle and injected into the egg in the laboratory, which is mainly it is taking place in the laboratory only. The next is retrograde ejaculation. That is, the sperm can be taken directly from the bladder and injected into an egg in a laboratory. Next is a surgery for ependymal blockage. That is, it is a bypass of blockage can be performed called vasoependymostomy. That is, the vas difference is reconnected to the ependymitis. So you can see in this picture that is disconnected, and the vas difference is being reconnected with the directly to the ependymitis, and it is called as a bypass surgery for the ependymal blockage. Next, for the women, one is the ovulation disorders. So we can able to get treated for this ovulation through the drugs. The fertility drugs can be prescribed, that is clomiphene, to increase the ovulation in case of PCOS, and metformin to the client who do not respond to clomiphene. We can go with this metformin mainly when a client with PCOS linked with the insulin resistance. Next is FSH hormone. The hormone produced by the pituitary, and it controls the estrogen production by the ovaries, and it stimulates the ovaries to mature the egg follicles. Mostly it can be done for the follicle stimulating hormones. Example Glonal F, Raponex, which is given in the subcutaneous. Human menopausal gonadotrophin, that is Brayvel, Raponex, Menopur given by IM and can also be given in subcutaneous, which is a genetically engineered product, contains both FSH and NH in case of absent ovulation due to pituitary dysfunctions. Next is a human chorionic gonadotrophin, that is, which is given in combinations with clomiphene plus HMG plus FSH. It stimulates the follicles to ovulate, which is given in both IM as well as in the subcutaneous. GnRH for women who ovulate premature follicle during HMG treatment. It delivers constant supply of GnRH to pituitary gland, which will alter the production of hormones that allows doctors to increase follicle growth with FSH. Mainly it is given by intranasal spray subcutaneous injections. Next is bromocriptine. It stimulates the ovulation by inhibiting the production of prolactin. That is, we need to inhibit the production of prolactin, but the prolactin it stimulates the milk production in lactating mothers. It can be given as a parlodel and Psilocet, which is given in the form of oral as well as in the IV injection. And next is the infertility counseling. So infertility counseling, mostly we are dealing the psychosocial impact of infertility in terms of intervention, treatment, after effects of both successful and unsuccessful treatment. Mostly the couples who are coming for the infertility treatment, they need a more counseling, very elaborated counseling for them to take a proper decision during this time, right? So mostly we are going to give in this infertility counseling session, that is a psychosocial impact, like what are the interventions available, what are the treatment that it is apt for the couples, and we have to able to get you able to take care of the couples even if they are successful as well as the unsuccessful too. Mostly, it involves the therapeutic work to help the patient cope with the consequence of infertility and childbirth. It is an objectives and need of infertility counseling. So it is in informed consent, yes, because it is the main legal and ethical issues are there in this infertility treatment. So we need to get a consent for each and every interventions and the treatment which is given to the couples, to offer coping strategies to couples, to facilitate decision making, to offer preparation for procedures, and the counseling services mainly they mean mostly we need to do for IVF, a group discussion by the staff, and a third party reproduction for both the donors and the recipients, therapeutic counseling, crisis counseling, and the assessment and the follow-up care. And what is the advantage of infertility counseling? It helps to deal with the emotional stress. Definitely, the couples will have more amount of stress because they would have tried more amount of treatments. They would have gone for IUI and IVF. Sometimes it may get failure. So we need them to we need to help them to come out of the emotional stress, and then it also helps to provide extra support for the patient, allow the client in exploring all possible options for the family, because during the counseling session the couples can able to ventilate their feelings and they can come with lot of doubts and questions so that they will get a clear ideas about the treatment of the infertility, helps couples in overcoming the dilemmas and deciding the right fertility treatment. Yes, so definitely they'll have a lot of dilemmas to which treatment can be accessed, even if it is get failure for first time. So we need to give them a proper guidance so that they can also go to the second time of the treatment, and they need to get a clear idea of the treatment. Explain about the infertility management specific treatment and the role of nurse in infertility counseling. So, receiving the patient family make them accessible and comfortable for the counseling. So, main thing we need to assist the whole family, because not only the couples are going to get emotionally stressed, the whole family is going to get emotional stress. So, we need to give them a comfortable during the counseling. The fertility nurse specialists provide care for the individuals and couples before, during, and after the fertility treatment. The nurse need to obtain a history as a prenatal, family, and other relevant history, because during the history collections we can able to get lot of information from the patient as well as from the families. That can be done very nicely with the nurses. The nurse has to perform a primary physiological examination and to collect all relevant information regarding the patient's reports, give psychological support throughout the counseling sessions, collect other information about test reports and the documents. So the nurse has to collect the proper previous documents, if the what are the tests they have done, what are the treatment they have undergone, and what are the reports they have. So all that will give a guidance for the doctors to give treatment for the patients and for the couples. Establish a plan of care with family and coordinate care with other healthcare professionals. So the nurse has to coordinate the proper care along with the family, along with the other healthcare professionals, and maintain privacy and the confidentiality of all cases. Definitely, the nurse has to play a major role in maintaining the confidentiality of the patient conditions. If they are not able, they should not discuss the condition with the other people. So it is mainly they have to maintain a privacy and the confidentiality of the couple cases. Performing insemination, performing embryo transfer, and ensure the follow-up and supportive services to individual family during the counseling. And last is the ethical and legal aspect of ART. So definitely in this infertility treatment, we are going to get a lot of ethical and legal issues and aspects that during this infertility treatment. So these are the technologies that we have to go, that we are going to see under ART, that is assisted reproduction technologies. So first, what is the aim of ART? Is to promote the chance of fertilization and subsequent pregnancy by bringing the sperm and egg close to each other. So this is mainly how the treatment is going to happen. It is they are going to bring the sperm and the egg closely each other, and they are going to treat and they are going to give them a birth. So they have a different types for making the sperm and the egg to get close each other. One is through intrauterine insemination. So this is the first line treatment for the infertility treatment. It is indicated as a first line management where there are problems such as hostile cervical mucus, anti-sperm or male fertility problem, that is low sperm count, premature ejaculation, or if the tubal patency of the female partners must be assured. It is also useful for the cases of unexplained infertility. If we can't able to find a cause for this, they have to go with intrauterine insemination. In order to increase the chance of success, so what are the interventions they have to do is ovulation to be monitored. So every day after the menses, that is 10 to 14 days, after the 10 to 14 days, that is when the ovulation period is been started, it has to be monitored through the scan. The ovulation is induced oftenly. So if we find that there is not a proper ovulation is been happening, so we can be able to induce with the help of drugs also. The sperms are prepared to maximize their fertility before insertion into the uterus. Next treatment is in vitro fertilization, that we commonly call as IVF embryo transfer. It describes the lab techniques where the fertilization occurs outside the body and is one of the main types of ART. IVF is indicated in case where the female partners ask. So when can be this IVF can be done in the sense of uterine tube occlusions, endometriosis or cervical mucus problem, or where a male factors or the main problem. The stimulation of ovaries are produced, then one egg is required and the treatment starts with the pituitary desensitization, which is done by the gonadotropin injections. Next treatment is called as intracytoplasmic sperm injection, that is ICSI, which is commonly called as ICSI, which is developed in the year 1992, and it is highly specialized variant treatment that involves the injection of single sperm into the cytoplasm of an IVF egg with a fine glass needle. It is useful technique when sperm quality is poor and the asospermic main sperm can be obtained surgically from the ependymitis or by extraction from the testis itself. So mostly this treatment is done for the male who don't have a sperm count, when they don't have a quality sperm. So they are doing this procedure with the help of extracting the sperm from the ependymis, or they are extracting directly from the testis and they are injecting with the sperm. Next treatment is gamete intrafallopian transfer or zygote intrafallopian transfer. So both these are done with a laparoscopic technique that offer little clinical advantages over in vitro fertilization and are no longer being recommended. and the third party assisted ART. What is this in the sense? When couple they do not achieve a pregnancy from the infertility treatment or a traditional ART, then they may choose to a third party assisted ART method to have a child. So what in the sense when the couples they have been taken treatment of what the treatment which is available for infertility, they have tried everything, so still they don't get a child, then they go to a third party assisted ART. That is, they will do the procedure with another person and they will have a child. One is through a sperm donation. So the sperm donation is a couple can be donated a sperm when a man does not produce a sperm or produce very low number of sperm, and if he has a genetic disease. So when the person is not able to have a proper sperm, or they have very low number of sperm count, or if they have if the man has a genetic disease, then they will go with the sperm donation treatment. Donated sperms can be used with the intrauterine insemination as well as with the IVF treatment. Next is the egg donation. It is mainly used for the women, from the women. It can be used when a woman does not produce a healthy egg that can be fertilized. An egg donor undergoes ovary stimulation and egg retrieval steps of IVF. So here, if the woman does not able to produce an a healthy amount of eggs, then they'll go with this egg donations. They will stimulate the ovary and they will retrieve the eggs, and then they'll use in the intraventral fertilization. The donated egg can then be fertilized by the sperm from the woman's partner, and resulting embryo is placed in the woman's uterus. Next is surrogacy. The legal arrangement for surrogacy required the beginning couples to both be over the age of 18, marry each other, and the child genetically related to at least one of them. So, what is surrogacy in the sense? If the male and if the woman they are not able to carry children in their womb, so they will get a surrogate mother, so that mother will get conceived with the sperm of its couple, male partner's sperm. Then it will be transferred with the help of intrauterine insemination, and that surrogate mother will conceive and they'll give birth to a child, and that child will be taken by this couple. But in this there is a lot of illegal there is a lot of legal and ethical aspect has to be considered, and then only we have to go with this surrogate mother treatment. Surrogate mother acts as a host as an embryo and is placed in the uterus. So she will be acting as a host in order to carry that egg in her uterus, and then the normal pregnancy will be taken place. So that's all about this infertility treatment. I hope I've given a lot of treatment about this infertility, and I'd like to thank our beloved principal ma'am for giving me this opportunity.